So it's just 8 o'clock, so I'm going to get started. So first of all, just want to thank everyone for tuning in this evening. I know as the evenings get brighter and the weather gets better, it's harder to get in, but this webinar is going to be recorded for anyone who has missed it or anyone who'd want to watch back for future reference. So I'm just going to do a quick little introduction to Rosie, a little bit about Premier Skills, and then I'm going to pass you over to Rosie for the webinar. It's going to be a great evening. She has loads planned. It's going to be really interactive. So it should be a good evening for everyone joining in. So just a little bit about Rosie. So anyone who's been to Premier Skills knows Rosie is a regular with us here. She's also the founder of the Ultrasound Vet, which provides scanning services to clinics in the west of Ireland mainly. Anywhere you meet Rosie, she'll be found imparting her love for ultrasound across anyone who will listen. Rosie also has experience in both GP level and referral level settings, both across Ireland and the UK. After completing her GP cert in diagnostic imaging, she took on the task of completing her PG cert in diagnostic imaging and is also in the process of getting her advanced certificate in cardiology. Apart from working and studying, Rosie loves teaching, lecturing, and providing CPD. Mostly what she does here in Premier Skills, it always gets great reviews. So she's teaching in ultrasound, radiography, CT is coming later this year. So her love and her enthusiasm for ultrasound is really infectious. So she hopes to pass it on to all of you this evening. So just a little bit about Premier Skills. So you may have noticed that we've changed our name in recent months. So we were previously Drug and Veterinary CPD, so we've changed to Premier Skills Institute in 2026. And this is really just to give us the opportunity to grow and develop in the future. So it's still the same courses, everything's still the same, but we just hope to improve and expand out a little bit in the future. So just for anyone who hasn't been with us in Thurles before, so just a little bit on our facilities. So we have a state-of-the-art clinical skills lab based in Thurles. So we have everything from our practicals from surgeries to ultrasound days to diagnostics. We have our conference room upstairs for group studies and or group for case studies and chatting and lectures and everything. So we really are lucky to have a state-of-the-art facilities based in Tipperary. So just a little bit on our courses. So we have a range of courses. So we have our webinars, which you're all on this evening and you're familiar about. We also have a full range of on-sites. So we've well equipped in the small. We're starting to expand out into the large animal and the equine. We have an excellent range of speakers, and all of our courses are accredited by the VCI. We also are in partnership with Improve International. So they have a range of certificates, GP level, PG, and for the nurses as well. So we collaborate with them to provide Irish vets and nurses certificates across the range. And then lastly, a new one that we kind of launched there towards the end of the year was our on demand. So this is our flexible learning. So everything is pre-recorded, uploaded to the website, and you can watch it and learn in your own time. All of these are also BCI approved, and this is definitely an area that's going to be expanding in the future. So here's just a little taste of some of our upcoming courses. So we have some webinars coming up. The soft tissue certificate is a blended course, both on-site and online. There's a little example of some of our on-demands that might be relevant for this time of the year. Rosie also has some courses coming up with us. Now, this is only a small selection, but we have the intro and intermediate ultrasound scanning. We have advanced ultrasound scanning, the new thoracic and abdominal radiology for vets. That's new coming in the year. We've CT for the nurses. We have ultrasound scanning and radiology for the nurses as well. So where to find us? So you can find us. We have our digital brochure and our website, both very friendly to use. So you can scroll across there and come across any of the topics that you may like. So that's everything from me. I'm going to pass you over to Rosie to let you get started. Oh, you're just on mute there, Rosie.
On mute. Sorry, that's not helpful. Let's try and share this screen. This is the part I'm always worst at doing, so let's give this a go.
Perfect.
See. What can you see, Siobhan?
Lovely. You can just see the
You
first
see the
slide
blood.
there, say the start. Yeah.
Fantastic. I'm just going to turn my video off as well because where I live, it's not great. I don't know how to turn my video off. Stop video. Can you all hear me but can't see me?
Yep, you're all good.
Great. Okay, so we'll crack on then, if that's okay. So, good evening, and welcome to this, what I hope is going to be an exciting lecture on leveling up your adrenal gland scanning. So, hunting for the elusive peanut, and on the right side, the arrowhead. So, thank you, Duggan Veterinary and Premier Skills Institute, for hosting this webinar this evening. Okay, so my name is Rosie, and I'm a peripatetic sonographer in Ireland, and I split my time between teaching diagnostic imaging and scanning. So I scan hearts and abdomens and anything else, really. I found over the years of teaching that no matter the proficiency of the sonographer, there is always a desire to shout from the rooftops when an adrenal gland has been identified, hence the lecture this evening. And I hope that by becoming more confident in not only identifying adrenal glands, but measuring and appraising them, you'll find a little bit more joy in your work as a clinician too. So I know we're all desperate to get right into it, but before we begin, we must delay a moment on an important physical concept. And this makes up exactly 4.65% of this lecture, so fear not, a tiny particle of physics. So ultrasound waves, they are mechanical oscillatory sound waves that are characterized by three things: frequency, wavelength, and amplitude. In all fairness, amplitude has very little bearing on how we operate as sonographers day to day, scan to scan, so this shall be ignored in this lecture. Frequency and wavelength, however, they have an inverse relationship. That is to say, as the frequency increases, the wavelength decreases. As the frequency decreases, the wavelength increases. So the smaller wavelengths of the higher frequency cause the ultrasound beam to be attenuated or used up in the superficial tissues. Lower that frequency down, and the larger wavelength can then penetrate further into the patient. Understanding the relationship between frequency and wavelength allows us to appreciate that there will always be an image resolution patient penetration trade-off. Therefore, probe frequency plays a very important role in what you can image, and most importantly, the quality of that image too. Higher frequencies, with their shorter wavelengths, are used to image superficial structures like the left kidney, adrenal glands, and right limb of the pancreas, for example. Lower frequencies are employed when imaging the deeper anatomy, such as the obtuse margins of the liver. So please always take this into consideration when scanning. The adrenal glands are actually relatively superficial structures and will benefit from a higher frequency employed to improve image resolution and allow you to identify them clearly. So time to focus. On the ultrasound machine, there is a button that can be used to adjust something called the focal point or focal zone. Ultrasound waves and their echoes are three-dimensional structures that are superimposed to create a 2D image that appears on our screen. Therefore, the 2D image, two-dimensional image, represents a volume of data that's been obtained. And the focal point denotes where the beam is narrowest and needs to be set at the level of interest. The left adrenal gland in this case here, yay. So this narrow focal point or cinch of the ultrasound beam is going to ensure that a smaller volume of data is collated to form the two-dimensional image that you're going to see on your screen. And this allows accurate representation of the tissues being scanned. So the focal point is usually denoted by a marker that's typically adjacent to the depth in centimeters on the screen. And I recommend setting a singular focal point, and this should be set to roughly the lower part of the structure under interrogation. And this focal point will improve lateral image resolution. So lateral resolution describes the ability to distinguish objects that are adjacent to one another at the same depth in a field of view. So adjusting the focal point to the correct position can improve image clarity and allow you better visualization of those adrenal glands, for example, making them pop from the surrounding tissues. Very helpful. So now let's turn our attention for a moment to probe movements, transducer movements. So ensure, especially for imaging small structures, that the probe is held like a pencil, thumb positioned kind of adjacent to where the notch of the transducer is. And this allows for fine millimeter specific movements to be made in one direction maybe and then another. If you grip the probe like a large animal vet about to enter a cow, sorry, well, the smallest movement you can make is going to originate from your wrist, which will not really be conducive to scanning those millimeter wide structures efficiently. Okay, there are plenty of ways to then move that probe over the patient, sliding, rotating, rocking, and fanning, but pressure seems to be a challenge for most sonographers, actually, as those that are new to sonography very typically apply far too much pressure. Clinicians always seem surprised, actually, at how very little pressure is needed to perform a scan. So more pressure might be necessary in tricky to image areas or to move gas on in the gastrointestinal tract. Less pressure, on the other hand, is often required for assessment of certain luminal organs to avoid, I don't know, organ collapse. So sometimes pressure is required, okay? But first, utilize the frequency and the depth, like we've spoken about, the depth or the field of view. Utilize those dials. Lower the frequency and increase the field of view to image deeper structures, for example. Remember, lower frequencies have bigger wavelengths. They can penetrate deeper into the patient. Let the machine and the probe do more of the work. If you don't consistently adjust the frequency during a scan and just decide to apply a lot of pressure to reach those deeper structures in a patient, okay, you're going to have a sore patient who might not be very conducive to scanning, and you're going to have a sore arm and curse the day you ever lifted a probe. But also, with the application of too much pressure, bye-bye important anatomical landmarks. So it's very common, especially while scanning the right adrenal gland, that too much pressure is applied. And this causes a collapse, or can cause a collapse, of the caudal vena cava, the CVC, which will make it really rather challenging to identify the right adrenal gland. So always ask yourself, as you scan, is this too much pressure that I'm applying? Now, we move on to the hunt. I hope you're all as excited as I am. So meet the adrenal glands. Yes, there are two of them. The left adrenal gland, fondly termed the peanut for its evident resemblance, and the right adrenal gland more typically represents an arrowhead. However, when we're scanning, we usually, most prominently anyway, see one half of the arrowhead, as indicated here. Now, I'm desperate to find out, how successful is your adrenal hunting? So Siobhan, hi. Siobhan's now going to release a poll, and I want you to fill in what's most applicable to you. So firstly, you tick box number 1 if you have never ever found an adrenal gland. Box number 2 if you find the left very easy, but you question, does the right adrenal gland exist? So you find the left maybe over 75% of the time. You click number 3 if you find the right easy, but the left is challenging. But to be honest with you, I don't think anyone has ever said that. But maybe you are the legend who finds the right adrenal gland over 75% of the time. And you click box number 4 if you can find both over 75% of the time. Are some
Okay.
answers rolling in, Siobhan?
Yep, the answers are just rolling in there, so I'll give people
Fantastic.
another minute. Um, no, the answers are flying in. Perfect. So if nobody else answers there, so the answers at the minute, so 47% said never have I ever.
Okay.
41% left easy peasy, does the right exist? So so out of everyone that's voted, that's 88% are the first two answers. And then it's one vote each on the third and the fourth.
I can imagine. So
Yeah.
fantastic. Thank you so much for your contribution there. Thank you, guys. And Siobhan, if you can save those answers, that'd be great for me. Thank you.
Yeah, I can do.
So, to make everyone feel a little bit better, I present some results from a survey I created on the use of ultrasound in small animal general practice that was answered by 93 small animal clinicians in Ireland. Now, when asked how confident these clinicians were at identifying adrenal glands, 84.9% of these clinicians who routinely employ ultrasound in practice were just not confident in scanning adrenal glands. So it's hard. Innately, it's hard. So let's bring it back to basics, particularly where the anatomy is concerned. Forgive my drawing here, but a basic understanding of vascular anatomy particularly is key to successful adrenal hunting. So when scanning the left adrenal gland, the aorta is the great vessel closest to your probe. When scanning the right adrenal gland, the caudal vena cava is the great vessel closest to the probe. The kidneys and the great vessels are the biggest landmarks sort of boxing in the adrenal glands. And we're going to delve into some of the smaller landmarks now shortly. Okay, we're going to begin with the left adrenal gland, the peanut, and you're going to position the patient in right lateral recumbency, probably the view everyone's most used to. And you're going to ensure the notch of the transducer is directed cranially towards the head of the patient, towards the machine. And you're going to locate the left kidney, which is going to become the lateral landmark for identifying the adrenal gland. And the left kidney is easily identified, typically just caudal to the last rib on the left, dorsally, adjacent to the sublumbar musculature. And the left adrenal gland will be located between the left kidney, which will be the lateral landmark, as I've said, and the aorta medially. Now, into more of the nitty-gritty. Arising from the aorta, typically just caudal to the left kidney, is the left renal artery, marked number 4 on this schematic. And this often has a hooked appearance as depicted here, directed cranially. It's in the nook of this left renal artery that the caudal pole of the left adrenal gland commonly resides. And it's the best place anyway to start the hunt. So 2 round anechoic structures are going to be present a little cranially along the aorta. And these are the celiac and cranial mesenteric arteries, typically imaged in transverse, so they appear as these little circles. And these vessels are typically the cranial landmarks, now helping us to narrow down the search radius when hunting for the left adrenal gland. I hope that makes sense. Once the left kidney has been identified in a longitudinal plane, you're going to fan your probe dorsomedially towards the ventral aspect of the vertebral bodies, adjusting the pressure as needed. Rotate the transducer slightly as required to obtain a reasonably longitudinal view of the aorta, and it's between the aorta and the left kidney that the left adrenal gland should be identified. Can you see it? Lovely little peanut. You can see it there with the visible cortex and medulla in this patient. I'll highlight it for you now again. There you go. Beautiful little peanut. Easy, right? So identifying the renal artery now is very important. As previously mentioned, the caudal pole of the left adrenal gland is often located in the hook or nook of this vessel. Can you identify the left adrenal gland in the cine loop, do you think? I'll let you look through it one more time. Hopefully it's quite clear for you. It does look quite like a vessel though. Now, sometimes a shadow as such or an impression of the adrenal gland can be seen. It might be only sort of semi-visible, like in the first image here on the left. A great trick when this is the case is a small rotation of the probe. I find approximately 15 to 25 degrees clockwise of rotation will often allow the caudal pole of the gland to sort of pop out. And from here, a measurement can indeed be obtained. Now, knowing what you know now, do you feel more confident at identifying the left adrenal gland in this cine loop by yourself? So let's watch it through 1 or 2 times. As I've mentioned, sometimes the cortex and the medulla of the adrenal glands may be visible, like in this patient. Other times not, though. It's just a variation. And actually, it's more commonly seen when a higher frequency is employed, oftentimes with a linear probe, for example, such as in this image here, conveying superior image resolution. Hopefully you all feel confident in seeing that little peanut. Okay, I think we might move on to the right adrenal gland. I hope you're up for the challenge. So now you're going to do this interesting positioning. Some of you may be used to this, some of you may not. But you're going to position the patient in left lateral recumbency. Head of the patient towards the ultrasound machine. Legs of the patient orientated away from the sonographer. That's very important. You're scanning the right side now. The notch of the transducer is still directed cranially towards the patient's head. And you're going to angle the probe towards the base of the vertebral column, just beneath the sublumbar muscles. Remain dorsolateral and apply pressure as you move medially. The correct amount of pressure is vital here. Remaining dorsally and applying an appropriate degree of pressure will allow the gassy bowel loops to be displaced ventrally, opening up the acoustic window for imaging the right adrenal gland. Gas, of course, is the bane of a sonographer's professional life. And I say professional life as I do have a toddler at home, and as such, other aspects of my life do leave me gritting my teeth. But gas will, of course, cause distal acoustic shadowing and signal dropout, meaning nothing distally to the gas barrier can be visualized. So the right adrenal gland is housed in a very dense, gassy area, gas central. It's housed adjacent to the descending duodenum, the pyloric outflow, the ascending colon, the right colic flexure, sometimes the cecum, gas central. So some pressure is needed, but too much pressure and you run the risk of squashing the landmark, which is the caudal vena cava for the right adrenal gland. This great vessel is closest to the transducer, as you can see here, very close to the transducer when scanning the right side of the abdomen, and can be compressed very, very easily. Perhaps some of you have already seen the right adrenal gland in that cine loop. In schematic form, though, it's absolutely more challenging than the left side, no doubt. The right renal artery and right renal vein add some vascular mayhem to the mix for sure. And I always feel that if I can identify the caudal vena cava and the celiac and cranial mesenteric arteries from the aorta again, there is hope for finding the right adrenal gland. Actually, the left adrenal gland is very often seen too from this view distally to the aorta. And the landmarks in situ, you have 1, the caudal vena cava, 2, the aorta distally to it when you're scanning the right side, 3 would be the cranial mesenteric artery in transverse, and 4, the celiac artery in transverse. This image has obviously been optimized for the right adrenal gland. And as I've already mentioned, it's very often only half of the arrowhead that is visualized while scanning the right adrenal gland. Okay, we're going to watch this little video I've created a couple of times to help with identification of the anatomical landmarks. This video comes from one of the reels on Instagram. There's the beautiful transverse celiac and cranial mesenteric arteries. The right adrenal gland shaped like an arrowhead properly in this image. Let's watch it through again. Caudal vena cava is closest to the probe. You can already visualize the right adrenal gland. Celiac and cranial mesenteric arteries. And the right adrenal gland. So in this video, the right adrenal gland as an arrowhead shape, I think, can be really, really appreciated. There it is. Hopefully you can appreciate that too. As we've seen, when hunting for the right adrenal gland, very often there appears to be that kind of mess of vasculature. We've just seen that in some videos there, in some cine loops. So always try to identify the caudal vena cava first, and the rest will typically then fall into place. Sometimes the adrenal glands can look not dissimilar to a vessel in a still image. So how might we confirm that it is indeed an adrenal gland and not a structure, apart from obviously fanning through and tracking it? We could use color Doppler. Okay, so this is often the easiest to do this in a transverse view. So rotating the probe now so the notch points dorsally can allow for images such as these transverse views to be obtained. With the application of colored Doppler, the vessels will highlight, provided of course the Doppler settings are correct, and the adrenal gland itself will not highlight. Now, obviously, the adrenal glands do have their own vascular supply, a little adrenal artery and a little adrenal vein that feed into and out of the middle, the cinched portion of the peanut. Don't be disturbed by them. They are small, highly functional, and will show a small amount of colour flow with Doppler, but the caudal vena cava will be the main vessel and the aorta that you see in a transverse view. And perhaps you've noticed by now, we've seen this in a couple of images and cine loops, that the right adrenal gland is very closely associated with the caudal vena cava. And in many instances, not all instances, but many, it shares its adventitia with the caudal vena cava. That's to say, the outer part of the right adrenal gland is the outer part of the caudal vena cava, histologically speaking. And it's due to this fact that right adrenal neoplasms can invade the caudal vena cava. It's a wow moment, I know. We're going to see this shortly though, so don't worry. Okay, So we all love ultrasound, obviously. Obtaining pretty pictures, it is the object of the game. Pretty pictures are diagnostic, right? But the best thing about ultrasound is that it is the most user-dependent imaging modality. The images are obtained in real time, and thus you must adapt and interpret as you perform. And honestly, no one is good at it off the bat. It really is just a numbers game. Scanning is just a numbers game. The more you scan, particularly the more you scan with a systematic approach, the better you will become. Okay, so now going forward, when you find an adrenal gland, yay, you will then attempt to scan it another 2 times. And when I began my journey as a sonographer, many years ago now, I imaged the adrenal glands on every patient 3 times. So I went through all the steps to identify and measure them 3 times, both sides, in every patient. And this really racked up my adrenal hunt numbers as such and accelerated my proficiency in scanning these trickier organs. I can recommend doing this for every organ, though, to be honest with you. So moving on to measurements, and does size really matter? Well, with regards to the size of the caudal pole of the adrenal glands, as with many things in medicine, there's much deliberation as to what the reference range is for normal. But the adrenal glands, well, honestly, they take it to a whole other level. Currently, we are going to measure we do measure the caudal poles of the adrenal glands and compare the left gland to the right gland. But there isn't much agreement on caudal pole size and what is normal. So this fantastic paper by Soulsby et al. In 2014 summarised multiple studies that suggested upper thresholds for a maximum measurement of the caudal pole of the adrenal gland in a sagittal plane. And they further evaluated whether each of these studies reported a correlation of caudal pole size with body weight or not. Okay, I know that's a lot of information, so I'm going to summarise. There are at least 8 studies looking at adrenal caudal pole measurements, at least 8. 4 studies indicate the left and right glands are of a similar size, but 3 papers determine the right adrenal gland is bigger. Helpful. Some papers report no upper threshold for normal at all. Very helpful. And this is the best part. Adrenal measurements and body weight were not correlated in 50% of the papers, and they were correlated in 50% of the papers. So what is currently employed by most sonographers? So we do indeed still measure the caudal pole of the adrenal glands. And I work off Soulsby et al.'s proposed cutoff values suggested for the following body weight categories. So less than 10 kilos, I want the caudal pole to be about 0.55 centimeters. I should be accurate, 0.54 centimeters. Between 10 and 30 kilos, I typically want less than 0.7 centimeters. And over 30 kilos at less than or equal to 0.8 centimeters. But Soulsby et al. Further state that there is stark variation in adrenal gland sizes between dogs, and they had the audacity to state further that the proposed cutoff value should be used cautiously until further studies are performed. Further studies, more studies. Any takers on that one? Not me, anyway. So Miller in 2003 coined the phrase that a radiologist with a ruler is a radiologist in trouble. So measurements are, of course, useful, absolutely, but always consider the meaning of measurements obtained in conjunction with the patient's signalment, history, clinical signs, and hematobiochemical parameters. Anyway, what might cause the adrenal glands to be bigger or smaller than the suggested reference ranges, or be overly conspicuous or barely visible, if you want to call it like that? So smaller. In patients with Addison's disease, the adrenal glands may be very small or not visible at all, with caudal poles typically measuring less than 0.35 centimeters. So 0.35 centimeters is considered small, irrespective of the size of the dog. With regards to long-term steroid use, bilateral atrophy of the adrenal glands is usually reversible within 1 month of stopping steroid treatment. Bilateral enlargement, this can be normal in larger breed dogs, and it's typical of patients, of course, with pituitary-dependent Cushing's. Unhelpfully for the sonographer, stress hyperplasia, it's a bit of a nuisance. It's a common cause of a mild to moderate adrenal enlargement, often occurring with concurrent disease, for example. Therefore, any enlarged caudal pole always has stress hyperplasia as a differential diagnosis. Very interestingly, I remember finding out about this, but trilostane therapy, so once you start Veteral, trilostane therapy can cause a further engorgement of the adrenal glands for a few months following commencement of treatment before they start to shrink. Thought that was very interesting. And when it comes to unilateral enlargement, a mass may cause one gland to become markedly enlarged. The effect this mass will have on the size of the contralateral adrenal gland will, of course, depend on whether this mass is endocrinologically active or not. That's a lot of information. I hope you're still with me. So now on to the best part of any lecture, how the theory works in real life. Okay, so let's have a little look at two case studies. Here's case study number one. So meet Ellie. She is an 11-year-old female neutered West Highland White Terrier. She was brought in for concern of PUPD, polyphagia, but recently rather hyperexic, not doing very well recently, moderate exercise intolerance, and thinning skin. Full clinical examination done, not by me. Obviously, I'm just the sonographer. But she had the abnormal clinical findings were a moderate pot-bellied appearance. I can indeed confirm that, and suspicion of calcinosis cutis, which we did indeed find, and scanned actually, which was kind of fun. Blood work-wise, she had monocytosis, ALT, a little elevated, alk phos nice and high, and cholesterol 11, with the upper limit being 8.26 millimolar liter. Urinalysis, no surprise, low specific gravity, and there was a trace amount of protein. So poll number 2, what is the primary clinical suspicion for Ellie? Siobhan wants to launch that poll for us now. Do you
Perfect.
think
You
it
should
could be,
see up there now.
thank you, Siobhan. Do you think it could be diabetes, hyperadrenocorticism or Cushing's, hypothyroidism, hypoadrenocorticism, or pregnancy in our 11-year-old female neutered West Highland White Terrier?
Perfect. Lovely. We're just getting a couple answers in there, so I'll give it another 30 seconds.
Fantastic. Hopefully everyone's still with us.
Perfect. If anyone else wants to throw in an answer. Perfect. Uh, the results show 92% of people said hyperadrenocorticism.
Yes, it absolutely seems like that. So that would be my primary clinical concern as well. Thank you, Siobhan. And due to Ellie's hyperexia and weight loss, the primary care clinician requested an abdominal ultrasound as well as an ATH stimulation test. So guess who the lucky sonographer was? It was moi. So this is beautiful here. Okay, you're going to love these images. So Ellie's liver was subjectively enlarged. This is the spleen, not the liver, but Ellie's liver was subjectively enlarged. The acute margins were rounded and the parenchyma was isoechoic to the spleen, suggesting a generalized increase of the liver, generalized increase in echogenicity of the liver. The spleen was, as you can see, it kind of looked like a starlit sky. So pinpoints of focal mineralization casting small distal acoustic shadows diffusely throughout the parenchyma. Absolutely beautiful. I love this finding. Concern for dystrophic mineralization here. So the kidneys, they were bilaterally symmetrical with a marked hyperechoic cortical speckling and mild renal pelvis dilation. I think this is the left kidney. The right kidney had a bit more of a renal pelvis dilation. And the left kidney, as illustrated here, demonstrated a solitary cortical cyst. So Cushing's syndrome can cause hyperechoic speckling of the renal cortex on ultrasound, primarily due to increased mineral deposition within the renal tubules and glomeruli, a condition which we sometimes call nephrocalcinosis. I think it's particularly evident in Ellie's kidneys. It's beautiful. It's even almost hard to spot the renal cortex there compared to the surrounding tissues. And of course, mild renal pelvis dilation is very often present when a patient is exhibiting PUPD. So question time. Siobhan will release a poll here now again for us. What is a common appearance of the gallbladder in patients with hyperadrenocorticism or Cushing's? Are we more likely to have a gallbladder that has gallbladder wall edema, cholecystitis, a biliary mucocele, or cholangitis? What do you think? The ultrasonographic picture of Cushing's.
Perfect. Lovely. The answers are still coming in.
Brilliant.
Great. If anyone else wants to throw in an answer there before I read out the results. Perfect. So we actually have a real mixture of
Okay.
results for this. 23% said gallbladder wall edema and cholecystitis, so 23% for both of those. 38% biliary mucol
Oh,
and
you can
15%
see.
cholangitis. You're not making it easy.
Siobhan, we're
They-
putting you through your phases here. Sorry, lovely. Thank you so much for that. That's fantastic. So it is indeed the biliary mucocele. Sorry, my machine seems to have decided it doesn't want to. There we go. It is indeed the biliary mucocele. In fact, patients with Cushing's are 22 times more likely to develop a biliary mucocele than any other patient. Um, of course, you could have a Cushing's patient with any of the other findings if there was pathology going on, but biliary mucoceles are a common finding in patients with Cushing's, as we can see. So what did I find? A beautiful example of a biliary mucocele appearing, as I'm sure you've heard, distinctly like a kiwi fruit in a transverse plane. I don't think any chef has ever said they're cutting a fruit in a transverse plane, but you know what I mean. So we can really appreciate here in the cine loop, but also in the still image, the hyperechoic sediment that's within the gallbladder lumen. It's slightly dependent, of course, but then you have these hyperechoic striations pulling in towards the central portion of the gallbladder, and in transverse view, it does look beautifully like a fully fledged gallbladder mucocele, like a kiwi fruit. Now, let's take a look at what Ellie's adrenal glands were doing. So the caudal pole of the left adrenal gland measured 0.48 centimeters in width, which is absolutely within normal limits for a small breed dog. But the cranial pole, as you can see in the cine loop, subjectively, was overly conspicuous. And when measured, it measured 1.18 centimeters. So very, very big. You see it there? Fantastic. So time to get those thinking caps on before we revisit Ellie now. I want you to think for a minute. I'm not going to ask a poll, but just think for a minute. How would you expect the adrenal glands to appear ultrasonographically in the following clinical situations? Would they appear increased, decreased, or remain kind of equivocal in size? What do you think? I'm going to give you a small bit of time to answer each of these yourself. So let's go. In a patient with pituitary dependent hyperadrenocorticism, would the left adrenal gland be bigger, smaller, or stay the same size? It would typically be bigger. The right adrenal gland, also bigger. That was pituitary dependent Cushing's. Addison's disease, we've already mentioned this. Both adrenal glands typically become smaller. How about systemic stress? Bigger, smaller, or equivocal in size? So yes, stress hyperplasia can cause an increase or not, depending on the patient, like this. The systemic stress, stress hyperplasia would be the increase in size. How about if you have an endocrinologically active left adrenal mass? So if we've got a mass on the left adrenal gland, the left adrenal gland is going to be big. If it's endocrinologically active, the right adrenal gland is going to become small. If you have a non-endocrinologically active left adrenal mass, the left adrenal gland has a mass, again, it's big. It's not endocrinologically active, so the right adrenal gland should be unaffected. So how did you get on with that? You can screenshot that if that's going to be helpful to you at all. Hopefully you got some of those answers correct. So back to Ellie. The caudal pole of Ellie's right adrenal gland measured 0.32 centimeters. So do you think this is considered a little small? Again, Siobhan has a poll. So this is considered a little small, true or false?
Perfect. There you go.
Hopefully we should be fairly fast off the bat with that one. Quick off the bat.
Yep, there's still a couple answers coming in, so I'll give you another couple seconds. Perfect. So the answer to, oh, there's no one more. So the answer for that was 67% true, 33% false.
Yeah, it is considered a little bit on the small side here, okay? It's considered a little bit on the small side. So the rest of Ellie's abdominal ultrasound was unremarkable. I mean, she had enough going on in there, okay? So this is why I've just commented on the structures there that we found abnormalities in. And there was an ACTH stimulation test. So the ACH stimulation test, clinical signs, blood work, urinalysis, and of course the ultrasonographic examination did support Cushing's disease, and she was commenced on medication. So her final diagnosis was adrenal dependent hyperadrenocorticism, and this occurs only in 10 to 20% of patients. As you know, most patients with Cushing's have pituitary dependent Cushing's. And the left adrenal neoplasm is either benign or malignant. And a repeat ultrasonographic examination or a contrast enhanced CT should be performed here for further clarity. And I love this case particularly as the primary care clinician whose case this was, it was her first ever Cushing's case. And as her first case, she gets an adrenodependent Cushing's. I thought that was fantastic. So, in summary, ultrasonographic findings that may be attributable to canine Cushing's include enlarged adrenal glands, unilateral or bilateral, increased hepatic parenchymal echogenicity with hepatomegaly very often, dystrophic mineralization anywhere and everywhere, typically the kidneys, the spleen, sometimes the liver and the skin, renal pelvis dilation due to PUPD, increased renal cortical echogenicity due to the dystrophic mineralization, and biliary mucocele. So it's certainly not all about those adrenal glands. Hope you enjoyed that case. Now it's time for a shameless plug. Okay, so the ultrasound vet, that's me, but sounds more professional, teamed up with Duggan Veterinary CPD, now the Premier Skills Institute, to create and implement a course called Ultrasound Plus, and it's about to enter its fourth cycle. So this course is a comprehensive ultrasound course that takes 12 months to complete, spanning 2 years. So it runs from July 2026 until June 2027. And apart from the great content, which is the primary draw, obviously, the course is accredited for 60 CVE points, the equivalent of 3 years of CPD requirements. So very briefly, I'm going to go through what we do. This is the plug part. Starting from July, so basically running for the whole of 2026, we look at abdominal ultrasound. So we meet for two practical days in July, an introduction to abdominal ultrasound, lecture and practical components. Then we have 4 pre-recorded webinars with questions online that you can answer and some case studies thrown in there too. This is going to cover ultrasound of all the organ systems within the abdomen. And then we meet in December for 2 more practical days, scanning the abdomen in more detail and ultrasound guided sampling practice too. Then, once 2027 rolls round, it's the fun time. January kicks off with the first pre-recorded webinar, which is ultrasound of the feline patient. That's my favourite one, actually. Then we have 2 online webinars dispersed, which are case studies, which are interactive case studies, kind of like what we've done today, but far more interactive. There is, of course, a webinar on ultrasound of the emergency critical care patient and a fun webinar on an introduction to echocardiography before we meet in June for the final practical, which is a good big quiz, and we practice scanning the heart and approaches to emergency scanning too. So if you or anyone you know might be interested in joining this epic ultrasound journey, don't hesitate to reach out for further information or just take the plunge and sign up. So I think Siobhan wanted to say 1 or 2 things here about Ultrasound Plus. Is that correct, Siobhan?
Yeah, I suppose just to kind of follow on from what Rosie said, suppose we're going into our 4th year and it's been a really popular course for the last couple of years. And it's really improved year on year. It's got better and better. And I really want to stress that it's open to everybody of all experiences. So don't feel like you wouldn't be good enough or you don't have the cases or you don't have the experience or anything. It's for everyone who recently graduated, you might be out a few years, maybe not so confident. And I really think this is a great course to try build your confidence. That Rosie has the course built that it starts from the real basics and builds your way up. So if you're a person who's interested in scanning, wants to get a bit more hands-on, you'd be surprised at once you have the confidence to throw a scanner on an animal that you will find yourself doing more cases. So wouldn't be worried about the caseload. And it's really open to everybody. And speaking to previous people who've on the courses before, they said it's transformed their scanning skills. And the benefits of it that you have your 5 practical days on site, but everything else is really flexible. It's all in your own time. And we have discussion groups that people can put in cases, ask for advice. So it's really interactive. It's a really great course kind of all around. So if anyone wants more details, my email address is there and I can chat to you tomorrow if anyone is interested in it. But I would highly recommend, and it's really for everybody.
Yeah, and the WhatsApp groups, they stay active. They're still going the other years, aren't they? Everyone still puts in cases. I don't know if you're still on them, Siobhan, I still am, but the cases stay going year after year after year. It's fantastic, really enjoyable. So thank you, Siobhan. Thank you for the input there. Okay, so moving on to conclude this lecture, we've got one final case study for you. Fantastic case. And this is Crumpet, and she's a 12-year-old female neutered Dachshund cross. I loved her name. Love a good crumpet. So she presented with lethargy, recent history of inappetence, plenty of whining at home. The owners were concerned for abdominal discomfort, and she presented 3 times to her primary care practice with suspected pancreatitis. So pancreatitis, repeat offenders for pancreatitis when they're old is never a good thing, right? Again, just the abnormal clinical findings. She was pale and she was tender on abdominal palpation. So blood work showed some changes, and the patient was treated empirically with a low-fat diet and pain relief. And being a more senior patient with recent episodes of weakness and discomfort, imaging was recommended. So guess what we did? Yep, you got it. We performed an abdominal ultrasound. And actually, the abdominal ultrasound was remarkably unremarkable, apart from an impressively large, isn't that beautiful, an invasive right adrenal lesion. So studies indicate that between 20 and 48% of adrenal neoplasms invade the caudal vena cava in dogs. Do you remember I talked to you earlier about how the adventitia is shared between the right adrenal gland and the caudal vena cava, and it's this histological feature in many patients that will allow for invasion of the right adrenal gland tumours into the caudal vena cava. So what are we looking at here? I'm going to click some arrows on when it's appropriate to do so. Hang on now. So we've got the cranial pole. Sorry, the caudal pole. That was the caudal pole. And we're going to look at now the cranial pole invading the caudal vena cava. And we can see the left adrenal gland there as well. So let's watch this clip through 1 or 2 more times. So you can see that beautiful cranial pole of the right adrenal gland that's invaded the caudal vena cava, floating almost within the vascular lumen. Probably my favourite cine loop to have ever obtained. It's the simple things. So the left and right adrenal glands were asymmetrical. The left adrenal gland measured 0.85 centimetres, still a bit big, and the right adrenal gland 1.6 centimetres at its widest point. So the caudal vena cava, this was the other thing I found, the caudal vena cava was notably enlarged in the caudal abdomen, distally to this mass, between 2 to 3 times wider than the portion of the caudal vena cava that was cranial to the tumoral invasion. And you can't appreciate it beautifully in this image. This image is the cine loop sort of focusing on the tumor itself, but you can see the status of flow caudally towards the right-hand side there of that lesion within the vascular lumen. And application of colour Doppler was really very pretty here. You can clearly see the direction of flow around the neoplasm. Now, I've employed the BART map. I don't know if you know about the BART map, but this colour variance map depicts flow away from the probe as blue and towards the probe as red. Blue away, red towards the probe. That's the BART map. And in cine loop form, you can really see the mass had well and truly invaded the caudal vena cava. Now, regarding adrenal masses, they can be benign, malignant, endocrinologically active, and endocrinologically inactive. Helpfully for us, there are a couple of ultrasonographic findings that might be indicative of malignancy. And these are localized or generalized loss of shape. Often they exceed 4 centimeters. They're heterogeneous. There can be calcification, irregular capsular margin, or invasion of surrounding structures. Now, further helpfully, adenocarcinomas far more commonly exhibit mineralization than pheochromocytomas, which only demonstrate mineralization about 10% of the time. So it's important to note actually that calcification or mineralization of the adrenal glands is an absolutely normal variant in cats, but in dogs it can be related absolutely to malignancy. Pheochromocytomas, however, they invade the caudal vena cava at a reported rate of between 30 and 80%. So they're much more locally invasive. And although most studies agree that there is a greater than 50% risk of CVC invasion with pheochromocytomas, we don't see it all the time, okay? But it is definitely a feature of pheochromocytomas. Okay, so what do you think? I think there's a poll for this, Siobhan. What's the most likely diagnosis for crumpet based on our ultrasonographic examination? So we have a right adrenal mass lesion that's mildly heterogeneous, invading the caudal vena cava with no evidence of mineralization. Do you think this patient has Cushing's disease, an adrenal myelolipoma, so a benign adrenal lesion, pheochromocytoma, or adenocarcinoma? What do you think?
The, the answers are just coming in there, so I'll give people another couple of seconds.
You're very good at these polls, Siobhan. I'm highly impressed.
Beginner's luck getting these up going the first
They're
time.
rolling out beautifully. You wouldn't
Perfect.
know you're a novice at this.
Perfect. I'll just give another couple seconds there. Perfect. Lovely. 41% for number three, 29% each for adrenal myolipoma and adrenocarcinoma, and zero for Cushing's.
Fantastic. Okay, so the answer is indeed a pheochromocytoma. I think that's our most likely option here because it is not mineralized, okay, and only 10% of them are ever mineralized, okay, and it has invaded the caudal vena cava. So invasion, local invasion is absolutely a feature of malignancy that makes adrenal myelolipoma very unlikely. So it's either going to be a pheochromocytoma or an adenocarcinoma, and pheos are the guys that like to invade. So I put my money here on pheochromocytoma. Okay, but what next steps would be most diagnostically rewarding in this case? And the owners will consider all options, okay, in this case. What do you think would be most rewarding, diagnostically rewarding? And there's a poll for this one too, the final poll of the evening. Would you go for a thoracic ultrasound ACTH stimulation test and blood pressure? A plasma norepinephrine test, contrast enhanced CT of the chest and abdomen and blood pressure? MRI of the adrenal lesion, we don't really do that in dogs, or tissue core biopsy of the adrenal lesion. Really don't recommend doing that in a dog. So what do you think?
Okay, the answers are just rolling in there. So I'll give people another minute or just another 30 seconds there.
I kind of ruled out two of them there.
Perfect. Lovely. If there's anyone else there, we want to get your answer in. Perfect. So 60% of people said um the plasma norepinephrine test CECT of the chest and abdomen.
Fantastic.
Um 27% said thoracic ultrasound ACTH simulation test, and 13% MRI of the adrenal lesion.
Fantastic. Okay. So firstly, MRIs of the abdomen. It's not commonly done in veterinary. We do MRI human abdomens. We don't commonly MRI our veterinary patients in the abdomens, just with the speed of the MRI scanner. We get too much motion artifact typically. So most of the time we would CT these lesions. Okay. So I'd probably pick CT because of the fact that we think it's a malignant neoplasm. I would want to definitely know what's going on in the chest as well. So I would love to have a contrast enhanced CT of the chest and abdomen. Blood pressure, important if you're thinking of pheochromocytoma. And of course, the plasma norepinephrine test. It's highly sensitive and specific biomarker for diagnosing canine pheochromocytoma. So I would indeed pick number 2 in this particular case. So I actually found out last week that Crumpet has been peacefully euthanized, which I'm sorry to say. I'm actually still awaiting the results, though, from the plasma norepinephrine test. So I hope to have the results from that soon. But I'm pretty confident in what the diagnosis was, bless her. So that concludes this lecture. Congratulations on your attention span, and thank you for joining us this evening. You're now ready to go scan those adrenal glands till it hurts. So I really hope this has been helpful for you, giving you a little bit more confidence in how to approach the adrenal gland scanning. But before you go, even if you could just take a photograph of this now, I would very much appreciate it if you could take the time this evening to fill out this survey. on the use of ultrasound in general practice. It's for small animal veterinarians only. It takes roughly 3 minutes to complete and will ensure I generate material and content for teaching that hopefully can continue to level up your scanning in practice. So if you please don't mind doing that, I would be incredibly grateful. Hopefully you photographed it, or the QR code. And so finally, are there any questions?
If there's any questions, people can throw them into the chat function down below, and we can answer any questions if needed. Whether it's questions about what Rosie mentioned in her lecture, questions in general about scanning, about any of the courses or anything. And if you can think of any questions now, our emails were listed there throughout. So if you think of a question in maybe an hour's time, if you want to pop it down an email, we can get back to you tomorrow too.
Absolutely. And Siobhan, the other lectures that we're launching this year are echocardiography lectures. We forgot to
Yes.
mention those. So we're doing a 2-day echo course twice this year. I don't know if there's many spots left, actually. I feel like the June date's fully booked. Um,
Um, June is fully booked. The date later in the year still has, I think it only has 4 or 5 places left.
Okay, perfect. So that's covering a kind of an introduction to echocardiography, but slightly more comprehensive than you would get in one day. And of course, if you are interested, you can find plenty of ultrasound tips, tricks, cases, and questions on my Instagram page. That's this QR code. And my Instagram page is the Ultrasound Vet. And thank you, Siobhan, Premier Skills Institute, for hosting this webinar. Any questions coming in, Siobhan?
No questions that I
Bunch.
can see. Perfect. So lovely. I think we can leave it there, and tomorrow I can, for anyone who's interested, I will send out an email with a link to all of Rosie's upcoming courses if anyone is interested. So I'll pop that out to you tomorrow.
Fantastic. Thank you so much again, and thank you for your attention. Good night.
Um, Thanks so much, Rosie.
Bye.
Bye.